Welcome back to the deep dive. We're here again, taking complex pharmacological source material and, well, really aiming to understand it at that elite professional level.
Absolutely.
We've talked about how drugs get in, how they distribute. Today, we're tackling the final part of that journey: metabolism, excretion, how the body gets rid of the drug, and the kinetics behind it all.
That's right. This is absolutely critical. Understanding how the body handles a drug chemically, how it eliminates it, that's fundamental if you really want to master drug therapy. Our sources are pretty detailed, so we're going beyond just definitions today.
Right, we need to get into the actual mechanisms, the enzymes, the calculations, the whole picture.
Exactly. The goal is that deep, granular mastery.
Okay, let's start with the core reason this whole system exists: biotransformation, chemical alteration in the body. Why does this even need to happen? Why not just excrete everything as is?
Well, it boils down to basic chemistry and physics, really. Most drugs need to be lipid-soluble, nonpolar to get absorbed easily to cross membranes.
Makes sense.
But that very property makes them really hard to excrete. The kidney's job is to filter waste and concentrate urine. If a drug is lipid-soluble, as the kidney pulls water back, the drug just diffuses right back across the tubule walls into the blood.
So it just keeps getting reabsorbed.
Exactly. It would just circulate endlessly, potentially becoming toxic. It would have an incredibly long duration of action.
So the body absolutely has to change it, make it water-soluble, polar.
Precisely. That's the imperative. Convert these nonpolar compounds into polar ones so they stay trapped in the urine and get flushed out. This whole system, biotransformation, it likely evolved as a defense mechanism against toxins, xenobiotics, foreign chemicals we might ingest.
So it's a survival mechanism, fundamentally.
You could say that, yeah.
But what if a drug is already water-soluble? Like you mentioned streptomycin in the outline.
Right. Hydrophilic drugs like streptomycin, they mostly bypass this. They don't need much chemical alteration because they're already water-soluble enough to be filtered by the kidney and stay in the urine. They get excreted largely unchanged.
But for most drugs, that conversion is key. And we always think of the liver as the main player here.
It absolutely is the primary site. The liver has the highest concentration of those key metabolizing enzymes, especially the cytochrome P450 system we'll get into.
But it's not the only site, right?
Not at all. The system is more distributed. The kidney itself has significant metabolic capacity. The intestinal wall is huge. Actually, it's the first place an oral drug encounters these enzymes. Even the lungs and enzymes floating around in the plasma like esterases contribute. It's a widespread defense network.
Okay, so the body chemically alters the drug. We usually think this means turning it off. But the clinical outcomes are more varied than that, aren't they?
They really are. There are three main possibilities. The most common one is inactivation.
Right.
The drug, or maybe an already active metabolite, gets chemically changed into something inactive or much less active. Think ibuprofen, paracetamol, propranolol. Metabolism effectively terminates their action. It's an alternative way to stop the drug working, besides just waiting for the kidney to excrete it.
Okay, that's straightforward. What's the second outcome?
This is where it gets more complex for predicting drug effects. Producing an active metabolite from an active drug.
Ah, so the effect continues, maybe even changes.
Exactly. The parent drug is active, but the body metabolizes it into another compound that's also active. Sometimes there's more than one active metabolite. The patient's overall response is then the sum of the original drug plus all its active metabolites.
Which means the effect lasts longer than you'd expect just looking at the parent drug's half-life.
Much longer, potentially. Codeine is a classic example. It's actually a prodrug for morphine. Most of the pain relief comes after it's metabolized to morphine. Digitoxin gets converted to digoxin. Diazepam, Valium, it gets metabolized to dismethyldiazepam and oxazepam, both of which are active and contribute to the long-lasting sedative effects. The body essentially gives itself extra doses.
Fascinating. And the third outcome seems almost backwards. Activation of an inactive drug, the prodrug concept.
Yeah, this is clever drug design. A prodrug is given in an inactive form.
Yeah.
It needs the body's metabolic enzymes to convert it into the active therapeutic agent.
Why do that? What's the advantage?
Oh, several potential advantages. Maybe the inactive form is more stable on the shelf, or it might have much better oral bioavailability. It gets absorbed better. Sometimes the active drug itself is too toxic if given systemically, or it can't reach the target site.
Like getting drugs into the brain.
Exactly. Levodopa is a perfect example. It's inactive but crosses the blood-brain barrier, which dopamine itself can't do effectively. Inside the brain, it's converted to dopamine, treating Parkinson's symptoms. Enalapril is another one. It's inactive, absorbed well orally, then converted in the body to enalapril, the potent ACE inhibitor for blood pressure.
Right.
Prednisone gets converted to prednisolone. Clopidogrel needs activation to its thiol metabolite to work as an antiplatelet agent. It's about optimizing delivery and sometimes reducing side effects.
Really sophisticated stuff. Okay, so these chemical changes, they're broadly classified into two phases, phase 1 and phase 2. Let's break those down. What defines phase 1?
Phase I reactions are often called nonsynthetic or functionalization reactions. Think of them as the prep step. Their main job is to stick a reactive chemical group, a functional group, onto the drug molecule, or maybe uncover one that's already there but hidden.
Like what kind of groups?
Things like hydroxyl, OH, carboxyl, COH, amino any chain U, sulfhydryl TITSH. Basically, they're adding or exposing a chemical handle.
A handle for what?
A handle for phase 2, usually. But importantly, the metabolite coming out of phase I might still be active, or could be inactive. It varies.
Okay, so phase I adds the handle. Phase 2 must use that handle, right?
Precisely. Phase 2 reactions are synthetic or conjugation reactions. Here, the body takes an endogenous molecule, something it makes itself, often derived from sugars or amino acids, and attaches it or conjugates it to that functional handle on the drug or the phase I metabolite.
And the point of attaching this big endogenous molecule is
To make the whole thing much more polar, much more water-soluble, and usually much larger. This makes it very easy for the body to excrete, typically in urine or bile. And the general rule for phase 2 is that the resulting conjugate is pharmacologically inactive.
usually inactive. But you mentioned exceptions earlier. We need to know those for that mastery level.
Right, there are important exceptions. Morphine is one. It undergoes glucuronidation, phase 2 reaction. But one of its metabolites, morphine 6-glucuronide, is actually more potent as an analgesic than morphine itself.
Wow. Okay.
Another is minoxidil, used for hair growth. Its sulfate conjugate is the active form. So while inactivation is the norm for phase 2, you have to be aware of these key exceptions. And remember, some drugs already have a suitable handle, so they can skip phase I altogether and go straight to phase 2 conjugation.
Let's dive deeper into phase I now. Oxidation is listed as the most important reaction type here.
By far. It covers a huge range of chemical transformations. Technically, it's the addition of oxygen or a negative radical, or the removal of hydrogen or a positive radical. This includes things like adding a hydroxyl group, hydroxylation, adding oxygen to carbon, nitrogen, or sulfur atoms, or chopping off alkyl groups, dealkylation. It's very versatile.
And these reactions can be quite energetic. You mentioned reactive intermediates.
Yes, that's a critical point. The initial step, often inserting an oxygen atom, can create these very short-lived, highly reactive chemical species, things like quinones, epoxides, superoxide radicals. Normally, they're quickly converted to stable metabolites.
But if that process goes wrong,
If the system is overwhelmed, or if the downstream detoxification pathways can't keep up, these reactive intermediates can damage cellular components like proteins and DNA. This is the basis for certain types of drug toxicity, most famously with paracetamol overdoses, we'll definitely come back to.
okay, so what's the machinery driving most of this oxidation? The monoxygenase system, the cytochrome P450 enzymes?
Exactly. The CYP450 system. It's a superfamily of enzymes, primarily located in the smooth endoplasmic reticulum of liver cells, though present elsewhere too. The name P450 is a bit historical. It refers to the fact that when the enzyme's heme iron is bound to carbon monoxide, it absorbs light maximally at 450 nanometers.
Just a spectral characteristic then. What are the essential components?
You need the CYP enzyme itself, which contains a heme group like hemoglobin. You need a source of electrons, which is NADPH. You need an enzyme called NADPH CYP P450 reductase to shuttle those electrons to the CYP enzyme. And you need molecular oxygen, O2. It's a complex electron transport chain.
Can you walk us through how it works conceptually?
Sure. The drug binds to the CYP enzyme. Electrons are transferred from NADPH via the reductase. This allows the CYP enzyme to bind and activate molecular oxygen. This activated oxygen is then inserted into the drug molecule, creating a hydroxyl group or other oxidized product. The enzyme is then regenerated to start another cycle. It's an elegant but complex process.
And there are tons of these CYT enzymes.
Over 100 isoenzymes identified in humans, yeah. We group them into families, CYP1, CYP2, CYP3, and so on, and then subfamilies like CYP3A, CYP3B. But clinically, a handful of these dominate drug metabolism.
Right. Let's focus on the key players we absolutely need to know. Which one handles the most drugs?
That would be CYP3A4 and its close relative CYP3A5. Together, they're responsible for metabolizing somewhere around 50% of all clinically used drugs. It's the major workhorse.
50%, that's huge. Where is it found?
primarily the liver, of course, but critically, it's also highly expressed in the wall of the small intestine.
Ah, so it contributes significantly to that first-pass metabolism for oral drugs.
Absolutely. A lot of drug is metabolized by CYP3A4 right there in the gut wall before it even reaches the portal vein to the liver. This means anything that inhibits CYP3A4 can dramatically increase the oral bioavailability of its substrates.
And given it handles so many drugs, it must be involved in countless drug interactions.
Countless. Think about inhibitors like ketoconazole, erythromycin, ritonavir, even grapefruit juice. They can cause dangerous increases in levels of CYP3A4 substrates like simvastatin, calcium channel blockers like verapamil, or older drugs like terfenadine. It's probably the most important enzyme regarding drug interactions. Okay, next major one, CYP2D6. This one's known for genetic variability, right?
Highly variable. CYP2D6 metabolizes about 20% of drugs, including many antidepressants like tricyclics and SSRIs, antipsychotics, beta blockers like metoprolol, and importantly, opioids like codeine.
And the variability means people metabolize these drugs very differently.
Dramatically so.
Hmm.
Based on genetics, people can be poor metabolizers, lacking functional enzyme, intermediate metabolizers, extensive metabolizers, the typical case, or even ultra-rapid metabolizers, having multiple copies of the gene.
What are the clinical consequences? Poor metabolizers might get toxic effects from standard doses because they can't clear the drug, or they might get no effect from a prodrug that needs 2D6 for activation. Ultra-rapid metabolizers might clear the drug so fast they get no therapeutic benefit, or they might rapidly convert a prodrug to its active form, potentially causing toxicity.
The codeine example illustrates the prodrug issue perfectly.
It does. Codeine itself isn't very analgesic. It needs CYP2D6 to convert it to morphine. So a poor metabolizer gets little to no pain relief from codeine. An ultra-rapid metabolizer might get too much morphine too quickly. And importantly, other drugs can inhibit CYP2D6. Quinidine, for example, is a potent inhibitor. If you give quinidine with codeine, you block the conversion to morphine, and the patient gets no analgesia. It effectively turns an extensive metabolizer into a poor metabolizer phenotypically.
Okay, moving down the list, CYP2C89, what's their significance?
These are particularly important because they metabolize several drugs with a narrow therapeutic index, meaning the gap between effective dose and toxic dose is small. Think warfarin, the anticoagulant.
Right, very sensitive.
Exactly. And phenytoin, an anti-seizure drug. Also drugs like carbamazepine. Even small changes in the activity of CYP2C89 due to genetics or interacting drugs can easily lead to toxicity, like bleeding with warfarin or loss of efficacy. CYP2C19 is another important one in this family, handling drugs like the proton pump inhibitor omeprazole, clopidogrel again, involved in its activation pathway, and diazepam. It also shows significant genetic polymorphism.
And CYP1A12, there's an environmental link here.
Yes, CYP1A enzymes metabolize things like caffeine and theophylline, but their notoriety comes from their role in activating certain environmental chemicals into carcinogens, so-called procarcinogens.
What activates these enzymes?
They are highly inducible, meaning their production is ramped up by exposure to certain chemicals. Key inducers are polycyclic aromatic hydrocarbons found in tobacco smoke and, interestingly, in charbroiled or grilled meat.
Now, smoking or eating a lot of barbecue could actually increase your risk from certain environmental toxins by boosting this enzyme.
That's the implication, yes. It links lifestyle and environment directly to metabolic pathways involved in cancer risk.
Finally, CYP2E1. What's its niche?
CYP2E1 handles smaller molecules, including ethanol, alcohol, and some anesthetics like halothane. But its most critical role clinically is in paracetamol, acetaminophen metabolism.
Back to paracetamol toxicity.
Right. At normal doses, most paracetamol is safely conjugated via phase 2 reactions. But a small amount is oxidized by CYP2E1 to form a highly reactive toxic intermediate called N-acetylp-benzoquinone-imine, or NABQI.
And alcohol comes into play how?
Chronic alcohol consumption is a potent inducer of CYP2E1, so someone who drinks heavily has much higher levels of this enzyme. If they then take paracetamol, even at doses that might be safe for others, they produce much more of the toxic NABQI, overwhelming the detoxification pathways and leading to severe liver damage.
That's a crucial interaction to know. Now, are all oxidation reactions handled by CYPs?
No, not quite. There's another class called flavin-containing monoxygenases, FMOs. They handle some drugs, like the H2 blockers, cimetidine and ranitidine, certain antipsychotics. The key difference is that FMOs are generally not inducible by other drugs and don't seem to be involved in as many drug-drug interactions as the CYPs. They offer a more stable metabolic route for their substrates.
Good distinction. What about the other phase I reactions, reduction and hydrolysis? Are they major players?
They're important, but perhaps less ubiquitous than oxidation. Reduction is the chemical opposite of oxidation. It can involve CYP enzymes working in reverse or other enzymes. Examples include metabolism of chloral hydrate or part of warfarin's metabolism. Hydrolysis involves using water to break a chemical bond, typically an ester or namase bond. This is done by enzymes called esterases and amidases found in the liver, plasma, and gut.
Examples.
Local anesthetics like procaine or lidocaine are rapidly hydrolyzed. Aspirin is hydrolyzed to salicylate. It's a common way to break down drugs with those specific chemical links.
And you mentioned some minor phase I reactions too.
Yeah, less common things like cyclization, where a linear molecule forms a ring, like proguanyl, becoming active cycloguanyl, and the opposite, decyclization, opening up a ring structure, which happens with some barbiturates.
Okay, that covers phase pretty thoroughly. Let's move to phase 2, conjugation. The goal here is always making the drug easier to excrete.
That's the primary goal, yes. Attach a large, polar, water-soluble endogenous molecule to make the drug highly ionized and ready for transport out of the body, usually via urine or bile. These reactions need energy, often from high-energy intermediates like UDP glucuronic acid or acetyl-CoA, but they tend to be faster than phase I once they get going.
Which conjugation pathway is the most important?
Glucuronide conjugation, without a doubt. This uses an activated form of glucuronic acid, derived from glucose, and enzymes called UDP glucuronosyltransferases, or UGTs.
Lots of drugs go this route.
A huge number. Chloramphenicol, aspirin, morphine, many benzodiazepines. It's also crucial for eliminating endogenous substances like bilirubin. Adding that bulky glucuronide group significantly increases molecular weight, often favoring excretion into bile rather than urine.
And that biliary excretion sets up something important, enterohepatic cycling. Can you explain that loop?
Ah, yes, this is a really key concept. So the drug glucuronide, let's call it DG, gets pumped into the bile, which flows into the intestine. Down in the gut, there are bacteria that produce enzymes called beta-glucuronidases.
And they do what?
They chop off the glucuronide group, liberating the original drug, D again. If that original drug is lipid-soluble, it gets reabsorbed from the intestine back into the portal circulation, goes back to the liver, and can circulate again.
So the drug essentially gets recycled.
Exactly. It prolongs the drug's presence in the body, increases its half-life, and can complicate dosing. Oral contraceptives are a classic example where this happens, contributing to their duration of action. Phenolphthalein, the old laxative, worked largely because of this extensive cycle.
Very important loop to understand. What's the next major pathway? Acetylation.
Right, acetylation. This involves adding an acetyl group using acetyl-CoA. It's important for drugs like sulfonamide antibiotics, the anti-TB drug isoniazid, and dapsone. The key thing about acetylation is genetic polymorphism.
Like with CYP2D6.
Very similar. There are different genes for the N-acetyltransferase enzymes, NET1 and NE2. People inherit different versions, making them either slow acetylators or fast acetylators.
And that affects drug response.
Definitely. Slow acetylators metabolize these drugs more slowly, so they're prone to higher drug levels and potentially more side effects like neuropathy with isoniazid. Fast acetylators might clear the drug too quickly and need higher or more frequent doses. It's a major source of individual variability.
Okay, what about methylation and sulfate conjugation?
Methylation adds a methyl group, important for some neurotransmitters like adrenaline and drugs like methyldopa or mercaptopurine. Sulfate conjugation adds a sulfate group, mainly to phenolic compounds and steroids. Both produce highly polar, easily excreted metabolites. Sulfate conjugation capacity can sometimes be limited, though, meaning it gets saturated at higher drug doses.
Now let's circle back to safety and detoxification. You highlighted glutathione conjugation. How does that work and why is it so vital?
Glutathione conjugation is the body's primary defense against those highly reactive electrophilic intermediates that can be formed during phase I. Oxidation, remember the NABQI from paracetamol?
Yes.
Glutathione is a tripeptide, and enzymes called glutathione S transferases, GSTs, attach it directly to those reactive molecules, neutralizing them very effectively. It's essentially a cellular mop-up system for dangerous electrophiles.
But the supply of glutathione isn't infinite.
That's the critical point. Under normal circumstances, the liver has plenty of glutathione. But in cases of massive overdoses, like with paracetamol, or when phase I pathways are heavily induced, like by chronic alcohol use increasing CYP2E1 activity, the production of reactive intermediates can overwhelm the glutathione supply.
And when glutathione runs out...
That's when disaster strikes.
Yeah.
The reactive intermediates, no longer neutralized, attack vital cellular components, proteins, lipids, DNA, causing covalent binding and leading to cell death, particularly liver necrosis in the case of paracetamol. Depletion of glutathione is the direct cause of toxicity.
A very clear link between metabolism and toxicity. Okay, before kinetics, let's clarify enzyme location and inducibility again. Microsomal versus non-microsomal.
Right. Microsomal enzymes are found mainly in the smooth endoplasmic reticulum of cells, primarily liver, but also kidney, intestine, lungs. This group includes the CYP450 family, the UGTs, glycuronidation, and epoxide hydrolases. The defining feature: they are inducible. Their production can be ramped up by exposure to drugs, dietary factors, or environmental chemicals.
And non-microsomal.
Non-microsomal enzymes are located elsewhere in the cytoplasm, mitochondria, or even in the plasma. Examples include esterases, amidases, alcohol dehydrogenase, and most conjugation pathways except glucuronidation, like acetylation, sulfation, methylation. Key difference: they are generally not inducible by drugs. However, they are often subject to that genetic polymorphism we discussed, like NAT enzymes for acetylation.
And this difference matters particularly for newborns.
Hugely. Newborns, especially premature infants, have immature or deficient levels of both microsomal and non-microsomal enzyme systems. Their ability to metabolize drugs is significantly lower than adults. This is why they are so much more susceptible to toxicity from certain drugs, the classic example being chloramphenicol, causing gray baby syndrome due to deficient glucuronidation, a microsomal UGT enzyme.
Makes sense. One last unusual elimination pathway: Hoffman elimination.
Ah, yes. This is unique. Hoffman elimination is the breakdown of a drug molecule that happens spontaneously in body fluids at physiological pH and temperature without needing any enzyme at all. It's purely a chemical rearrangement.
Which drug does this?
The methyl relaxant atracurium is the prime example. Its breakdown is independent of liver or kidney function, which is a major advantage in critically ill patients who might have organ failure. It just degrades on its own in the bloodstream.
Fascinating. Okay, let's talk interactions, building on induction and inhibition. Enzyme inhibition, you said this is fast-acting.
Very fast, often within hours of taking the inhibiting drug. The inhibitor molecule directly interferes with the enzyme, maybe by binding to the heme iron in CYPs or just competing strongly for the active site. Common culprits include azole antifungals like ketoconazole, macrolide antibiotics like erythromycin, protease inhibitors like ritonavir.
And the consequence?
Metabolism of the victim drug, the one that uses that enzyme, slows right down. Its clearance decreases, its half-life gets longer, and if it's an oral drug with high first-pass metabolism, its bioavailability can shoot up dramatically. This rapid increase in drug levels is often what precipitates toxicity.
But inhibition can be used therapeutically, the boosting strategy.
Exactly. A prime example is in HIV therapy. Ritonavir is a potent inhibitor of CYP3A4. Doctors give a low dose of ritonavir not for its own antiviral effect, but specifically to inhibit the metabolism of other HIV protease inhibitors like saquinavir or lopinavir. This boosts their levels, allowing for lower or less frequent dosing of the main drug, which improves adherence and can overcome some resistance. It's using an interaction to clinical advantage.
Clever. Now contrast that with microsomal enzyme induction. This is slow.
Much slower. Induction involves the inducing drug signaling the cell nucleus, often via specific receptors like PXR or AHR, to make more enzyme protein. It's increasing the actual amount of CYP or UGT enzyme. Because it requires gene transcription and protein synthesis, it takes time, typically 4 days to maybe 2 weeks, to reach full effect.
And the effect lasts after stopping the inducer.
Yes, because you have all this extra enzyme protein around. It takes time for those enzyme levels to return to normal baseline after the inducer is stopped. Could be 1 to 3 weeks.
And inducers are often specific to certain enzyme families.
Generally, yes. For example, classic anticonvulsants like phenytoin, carbamazepine, phenobarbital, and the antibiotic rifampin are potent inducers, primarily the CYP3A family, but also others like CYP2C. Cigarette smoke, as we said, induces CYP1A. Alcohol induces CYP2E1.
What are the main clinical consequences we need to watch for with induction?
3 key things. 1, decreased effect of drugs that are normally inactivated by the induced enzyme. The classic is rifampin-inducing CYP3A4, which rapidly metabolizes the estrogen in oral contraceptives, leading to contraceptive failure, big clinical problem.
Right.
2, increased toxicity from drugs that are activated by the induced enzyme or produce toxic metabolites via that enzyme. Paracetamol toxicity being worse in patients on inducers, like chronic alcoholics or those on certain anticonvulsants, is the prime example. They make more NABQI faster.
Got it.
And 3, Tolerance. If a drug induces its own metabolism, autoinduction, its effects may decrease over time, requiring dose increases. Carbamazepine is well known for doing this.
Okay, one more metabolic concept. Blood flow limited metabolism. When does blood flow become the bottleneck, not the enzyme?
This applies to drugs that the liver is incredibly efficient at removing. We call them high extraction ratio drugs. Examples include lidocaine, propranolol, morphine. The liver's enzymatic capacity to metabolize these drugs is so massive, it can basically eliminate almost all the drug presented to it in a single pass.
So the enzymes aren't saturated.
Not at all. The limiting factor becomes simply how fast the blood can deliver the drug to the liver. Changes in liver blood flow directly impact the elimination rate of these drugs, much more than changes in enzyme activity itself. For instance, drugs that reduce liver blood flow, like propranolol itself, by reducing cardiac output, can slow the metabolism of other high-extraction drugs like lidocaine, potentially causing toxicity. It's a delivery problem, not a processing problem.
Understood. Let's follow the drug out now. First pass metabolism revisited. Where does it happen?
It's the metabolism that occurs before the drug gets into the main systemic circulation after oral administration. Two key sites. The intestinal wall, remember CYP3A4 is there, and then after absorption into the portal vein, the liver. The drug has to run this gauntlet before reaching the rest of the body.
Which routes avoid this?
Anything that doesn't go through the gut and portal system first. So sublingual, under the tongue, transdermal skin patch, rectal partially avoids it, and of course parenteral injection for no SC.
And the consequences of high first pass metabolism.
Well, the oral dose needs to be much higher than the IV dose to get the same effect. Think morphine or nitroglycerin. There's often large variability between individuals in how much drug survives the first pass. And paradoxically, in severe liver disease, the oral bioavailability of these drugs might actually increase because the damaged liver can't extract them as efficiently.
And this leads to the formal definition of bioavailability.
Right. F is the fraction of the administered dose that reaches the systemic circulation unchanged. It accounts for both incomplete absorption and loss due to first-pass metabolism in the gut wall and liver. So F fraction absorbed X, 1 extraction ratio.
Okay, moving beyond the liver, what are the other ways out? Non-renal excretion.
So the main one is feces, primarily via bile.
Yeah.
Drugs, especially larger ones, molecular weight over 300 to 500 a day, and conjugates, like glucuronides, are actively pumped into the bile by transporters in the liver. But remember, enterohepatic cycling, what goes into bile might get reabsorbed, so fecal excretion is only the net amount that doesn't get recycled.
Wells.
Exhaled air is crucial for volatile substances, general anesthetic gases, alcohol. The lungs act as an excretory organ for these. And then there's milk.
Important for breastfeeding mothers, how do drugs get into milk?
Mostly passive diffusion. Lipid-soluble drugs cross more easily. Less protein-bound drug crosses more readily. There's also a slight pH difference. Milk is a bit more acidic, pH 7.0, than plasma, pH 7.4. This can cause ion trapping of weak bases, making their concentrations slightly higher in milk than plasma. Generally, the total amount excreted is small, but it's enough to warrant caution with many medications during lactation due to potential effects on the infant.
Okay, finally, the kidney. Renal excretion. This is the main route for most drugs and metabolites, right?
For water-soluble compounds, yes. It's the net result of three processes: glomerular filtration, tubular secretion, and tubular reabsorption. Net excretion, filtration plus secretion, reabsorption.
Let's take them one by one. Glomerular filtration.
This happens at the glomerulus. It's like a sieve. Small molecules, including drugs not bound to plasma proteins, get filtered freely from the blood into the tubular fluid. The rate depends on renal blood flow and how much drug is free, not protein-bound. And it naturally declines with age, typically starting after age 50, which is a major reason for dose adjustments in the elderly. Next, tubular reabsorption. This is mostly passive.
Yes, primarily passive diffusion back from the tubular fluid into the blood. This depends heavily on the drug's properties, its lipid solubility, and its ionization state in the urine.
This is where making the drug polar really matters.
Absolutely. Highly polar ionized drugs can't easily cross back through the tubular membranes. They stay trapped in the urine and get excreted. Non-ionized, lipid-soluble drugs can diffuse back easily, especially as water is reabsorbed and the drug concentration in the tubule rises.
And we can manipulate this with urine pH, the pH trapping idea.
Exactly. This is a key clinical application. Urine pH varies, but we can change it. Weak acids, like aspirin, barbiturates, are less ionized in acidic urine, so more reabsorbed, but become highly ionized in alkaline urine, so less reabsorbed, more excreted. Weak bases, like amphetamines, are the opposite. They ionize more in acidic urine.
So in poisoning with a weak acid like aspirin or phenobarbital, we can give sodium bicarbonate intravenously to make the urine alkaline. This traps the ionized drug in the tubule, enhances its excretion, and helps treat the overdose. For weak base poisoning, acidifying the urine would theoretically work, but it's generally too risky due to potential systemic acidosis.
Okay, the third process, tubular secretion. This is active transport.
Yes, an active energy-requiring process, mainly in the proximal tubule. It uses specific transporter proteins to pump drugs from the blood into the tubular fluid, even against a concentration gradient. There are separate systems for organic acids, using organic acid transporters, OATs, and organic bases, using organic base transporters, OCTs.
And protein binding isn't a barrier here.
Interestingly, no. Unlike siltration, active secretion can pull drug molecules off plasma proteins. As the transporters remove free drug from the blood near the tubule, more drug dissociates from albumin to maintain equilibrium, effectively feeding the transporter. So secretion can be very efficient even for highly protein-bound drugs.
And because it uses transporters, there can be competition.
Yes, fierce competition. Drugs that use the same transporter system compete for secretion. Probenecid is the classic example. It's an organic acid that strongly competes for the OAT system.
How is that used clinically?
It was famously used to prolong the action of penicillin, another organic acid, by blocking its secretion, keeping its levels higher for longer. Probenecid also inhibits the reabsorption of uric acid, which also uses OATs, so it increases uric acid excretion and is used to treat gout. It can either decrease or increase net excretion depending on whether secretion or reabsorption is the dominant process for the other drug using that transporter.
Okay, that covers the how. Now let's get into the how fast the kinetics of elimination. What's the fundamental parameter here? Clearance. CL.
Clearance is absolutely fundamental. It's not an amount, it's a volume concept. CL is the theoretical volume of plasma that is completely cleared of the drug per unit time. Example, ml-min or LHR. It relates the rate of elimination to the drug's concentration in the plasma. The equation is CL, rate of elimination, plasma concentration C. It's the key parameter for determining dosing rates.
And how the rate relates to concentration defines the order of kinetics. Most drugs follow first order.
Yes, most drugs at therapeutic doses follow first-order kinetics. This means the elimination systems, enzymes, transporters, are not saturated. The rate of elimination is directly proportional to the drug concentration. Double the concentration, you double the elimination rate. A constant fraction or percentage of the drug is eliminated per unit time. And crucially, clearance, CL, remains constant regardless of the dose or concentration.
Contrast that with zero-order kinetics.
Zero-order kinetics happens when the elimination system is saturated. It's working at its maximum capacity. Think of a bottleneck. The rate of elimination becomes constant and independent of the drug concentration. A constant amount, a shift mAg per hour, is eliminated per unit time, not a constant fraction. Alcohol is the classic example.
What happens to clearance in zero order?
Clearance is no longer constant. It actually decreases as the concentration goes up because the elimination rate stays flat while concentration rises. This is also called capacity limited or Michaelis-Menten kinetics.
And some drugs transition between the two. Nonlinear elimination.
Yes, this is really important and often dangerous. Drugs like phenytoin, warfarin, theophylline, they might follow first-order kinetics at low doses. But as the dose increases, their elimination pathways get saturated and they transition towards zero-order kinetics.
Why is that dangerous?
Because once you hit that saturation point, even a small increase in dose can lead to a disproportionately large jump in plasma concentration and potential toxicity. It makes these drugs very difficult to dose safely, often requiring therapeutic drug monitoring.
Let's talk about the parameter clinicians probably use most often, plasma half-life.
Half-life is simply the time it takes for the plasma concentration of a drug to decrease by 50%. It's a very useful concept, but it's important to remember it's a derived parameter.
Derived from what?
It depends on the two primary independent parameters, volume of distribution, V, and clearance, CL. The formula is T20 TFU to 0.693 by ECL. 0.693 is the natural log of 2.
So changes in either V or CL will change the half-life.
Exactly. If a patient develops kidney failure, their clearance decreases, and the half-life of renally cleared drugs will increase. If a patient becomes edematous, their volume of distribution might increase, which would also increase the half-life, even if clearance stays the same.
What's the clinical rule of thumb for elimination based on half-life?
The key rule is that it takes approximately 4 to 5 half-lives for a drug to be essentially completely eliminated from the body, over 94% eliminated after 4.5, over 97% after 5t.5. This assumes first-order kinetics, where the half-life is constant.
What about under zero-order kinetics?
The concept of a constant half-life breaks down in zero-order kinetics. Because a constant amount is removed per unit time, the time it takes to drop by 50% gets longer as the concentration gets higher. So half-life isn't a fixed value and isn't as useful.
Okay, all this kinetics leads to designing dosage regimens to achieve a steady-state concentration. How does that work?
When you give repeated doses of a drug at regular intervals, the drug level will rise and fall with each dose, but it will accumulate until the amount administered over a dosing interval exactly equals the amount eliminated over that same interval. This is steady state. The concentration will then fluctuate around an average Cpss.
And how long does it take to reach steady state?
It takes the same 4 to 5 half-lives. This is the plateau principle. Regardless of the dose size, steady state is achieved after 4 to 5 t and out. The level of the steady state depends on the dose rate and clearance, but the time to reach it depends only on the half-life.
How do we calculate the dose needed for a target steady state level?
For continuous infusion or for average CPS with intermittent dosing, the formula is dose rate target CPS SXCL. If it's an oral drug, you need to account for bioavailability. Oral dose rate target CPS SXCLF.
And we can manage the ups and downs, the fluctuations?
Yes. The size of the fluctuations between the peak, highest concentration, and trough, lowest concentration, depends on the dosing interval relative to the half-life and the dose size. Giving smaller doses more frequently reduces the fluctuations, which can be important for minimizing side effects linked to peak levels or ensuring efficacy isn't lost at the trough.
Sometimes we need to get to that steady state faster, especially if the half-life is long. That's where loading doses come in.
Exactly. If a drug has a very long half-life, like days, waiting 4 to 5 half-lives to reach therapeutic levels might be too long clinically. So we give a loading dose. This is a larger initial dose or a series of doses designed to rapidly fill up the volume of distribution and achieve the target concentration quickly.
So the loading dose calculation depends on V.
Primarily, yes.
Yeah.
Loading dose, target concentration XVF for oral. It's about filling the tank.
And the maintenance dose.
The maintenance dose is the regular, smaller dose given afterwards to maintain that steady state. Its job is simply to replace the amount of drug eliminated between doses. Since the rate of elimination is determined by clearance, the maintenance dose rate is governed by CL. Maintenance dose rate is at target CPSX XCL. Fill the tank with V, keep it full by matching CL.
But even with these calculations, people vary so much. That leads to therapeutic drug monitoring, TDM. When is it most useful?
TDM is crucial when there's a lot of pharmacokinetic variability between individuals and the drug has a narrow therapeutic window, low safety margin, and it's hard to judge the clinical response directly. Think digoxin, lithium, aminoglycoside antibiotics, phenytoin, theophylline. It's also vital in situations like kidney or liver failure where clearance might be unpredictable, or if a patient isn't responding as expected or showing signs of toxicity.
How do you sample? Peak or trough?
It depends on the drug and the goal. For drugs needing a constant effect above a minimum level, like antibiotics, anticonvulsants, you usually measure the trough concentration right before the next dose to ensure it's still therapeutic. For drugs where peak levels might correlate with efficacy or toxicity, like aminoglycosides, you might measure the peak level, typically 1-2 hours after an IV dose or a bit later after oral.
When is TDM not generally useful?
It's not needed if the drug's effect is easily measured clinically, like blood pressure for antihypertensives or blood sugar for insulin. It's not useful for prodrugs where you need to measure the active metabolite, like levodopa, and it's not helpful for hit-and-run drugs.
Hit-run.
These are drugs where the pharmacological effect lasts much, much longer than the drug stays in the plasma. Omeprazole is a perfect example. It irreversibly binds to the proton pump, so its acid-suppressing effect lasts for days, long after the drug itself is gone from the blood.
Yeah.
Measuring the plasma level tells you nothing about the ongoing effect.
Okay, let's wrap up with some advanced strategies. Why would we want to deliberately prolong drug action?
Several good reasons, mainly to reduce how often the patient needs to take the medication, which improves compliance. Also, to smooth out the peaks and troughs in plasma concentration, which can minimize side effects associated with high peaks and prevent loss of efficacy when levels dip too low.
How can we achieve this? First method, prolonging absorption.
Right. For oral drugs, this means using controlled release or sustained release formulations. These pills or capsules are designed to release the drug slowly over many hours as they pass through the GI tract, maybe turning a 3-times-a-day drug into a once-a-day drug.
And for injections?
We can inject the drug in an insoluble suspension, like some insulin's lente means slow, or dissolved in an oily vehicle, depot injections, like for some antipsychotics or hormones. The drug then slowly leaches out from the injection site over weeks or months. Transdermal patches also provide slow, continuous absorption through the skin, like nicotine or fentanyl patches.
Second method, increasing plasma protein binding.
Yeah, if you can chemically modify a drug to make it bind more tightly to plasma proteins like albumin, only a small fraction will be free and active at any time. The protein-bound drug acts like a reservoir, slowly releasing free drug as it gets eliminated, thus prolonging the action. Sulfadoxine is an example where high protein binding contributes to its long half-life.
Third, retarding metabolism.
2 ways here. You could slightly change the drug's chemical structure to make it less vulnerable to metabolic enzymes, like adding the ethanol group to estradiol makes it much more resistant to oxidation than natural estradiol. Or you can deliberately co-administer an enzyme inhibitor. We already talked about ritonavir boosting other protease inhibitors or using cilastatin to protect the antibiotic imipenem from being broken down by a kidney enzyme.
And fourth, retarding renal excretion.
This usually involves blocking active tubular secretion. We saw this with probetasad blocking the OAT transporter, which slows down the excretion to penicillin, making it last longer.
Finally, moving towards more futuristic approaches. Targeted drug delivery. What are the key examples?
2 main ones are liposomes and drug-releasing implants. Liposomes are tiny artificial vesicles made of lipid bilayers, and you can load drugs inside them. When injected, they tend to be taken up by specific cells like macrophages in the liver and spleen, the reticuloendothelial system, or sometimes accumulate in tumors. This can concentrate the drug where it's needed and reduce exposure to the rest of the body. Liposomal amphotericin B for fungal infections is a key example, much less toxic than the standard form.
And implants.
These are devices placed in the body that slowly release a drug over a long period. Think of progestin-releasing IUDs for contraception or drug-eluting stents placed in coronary arteries. After angioplasty, they release drugs locally to prevent restenosis. It's about getting the drug right to the target site and keeping it there.
Amazing technology. Okay, this has been an incredibly detailed journey through metabolism, excretion, and kinetics. We've gone from why lipid solubility forces metabolism, through the specifics of CYP enzymes and kidney transporters, right to the math of clearance and half-life.
It really covers the entire out phase of pharmacokinetics, and hopefully connecting it back to clinical examples like the rifampin oral contraceptive interaction.
Right. That really hammered home the impact of enzyme induction. Rifampin boosts the enzymes that chew up the estrogen, contraception fails. It's not magic. It's predictable pharmacology if you understand the mechanisms.
Exactly. It shows why this deep understanding is crucial.
So thinking about someone aiming for that elite professional mastery, what's the final provocative thought to leave them with after this deep dive?
I think it's this. We talk about drug doses like 500 milligrams of this or 10 milligrams of that, but because of everything we've discussed, the incredible variability in CYP enzymes due to genetics, the impact of inhibitors and inducers from other drugs or even diet, the changes in kidney or liver function, that dose on the bottle is really just a starting point, a suggestion.
It's not a fixed law.
Not at all. The actual effect in any given patient is the result of a constant dynamic negotiation between the drug, that person's unique genetics, their environment, their other medications, their organ function. True mastery isn't just knowing the pathways or the formulas. It's about appreciating and, where possible, predicting the outcome of that individual negotiation happening inside every single patient. That's how we optimize therapy and truly minimize harm.
The dose as a negotiation? That's
Yeah.
a powerful way to think about it, a constant interplay within the patient. Thank you. That was incredibly insightful, a really comprehensive deep dive.
My pleasure. It's complex but fascinating stuff.
Absolutely. And thank you all for joining us on the deep dive. We'll be back soon to tackle another complex topic.